Hello and welcome to It's Personal, brought to you by Gundersen Health System. Coming up, you'll learn about women's health. Most women in this area are aware of Gundersen's reputation in the women's health department, but we're going to talk with an expert about what makes Gundersen's program stand out. Also, when someone mentions Botox, what comes to mind? Reporter Brian Gilbert's will have the very latest on the different uses for Botox. And later, it used to be that total knee replacement was the best surgical option for people with chronic knee pain. But now partial knee replacement is a practical option. We'll explain. All next on It's Personal, brought to you by Gundersen Health System.
As a runner, Michael Bodie thought he was pretty healthy. However, his family history had something different to say.
I ran a half marathon, and 2 months later I had quadruple bypass. One artery was 90% blocked, one was 98% blocked, and one was 80% blocked, so they said, we have to do surgeries. That same day, the surgeon came in.
Like a true champion, Michael found a way to quickly get back in the game.
The minimally invasive route was attractive to me because it offered me at least a chance to possibly recover quicker and get back to my normal life faster than I would have been able to with the traditional surgery.
A leader in minimally invasive cardiac surgery, Gundersen provides expertise and an unmatched level of care.
The folks at Gundersen are rock stars. 2.5 weeks after my surgery, I started in cardiac rehab and actually ran on the treadmill. And a year later, I ran another half marathon.
Gundersen Health System, where caring meets excellence. For more of Michael's story and to learn your risk for heart disease, go to gundersenhealth.org/knowyourrisk.
Welcome back to It's Personal. I'm Christopher. Well, the reputation for women's health at Gundersen Health System is something that many people in our community are aware of. Pam Podesky joins us now from Gundersen's Women's Health Program to talk a little bit more in depth about why the program is so successful.
First of all, this has to be just great news for women in this area that Gundersen Health System is among the top 5% of hospitals for women's health. That sounds like outstanding news. Why?
It's outstanding news for the women in our community because it proves to the community that Gundersen has what only 5% of hospitals have in this country. And the two main factors that it looks at are mortality rates and complication rates. So to be in the top 5% of having the lowest mortality rates and lowest complication rates for care to women is outstanding.
Talk a little bit about how hard it is to get to that level.
It takes a lot of work on many people's parts. As you know, and people who know a little bit about the Health Grades Women's Health Award, it's an award that involves cardiology, bone care, and women's medicine. So it's not one subspecialty. It's a combination of several specialties, so it takes everyone to do outstanding work to achieve a top 5% rating.
Now, getting all of those subspecialties or specialties to work together in what's called an integrated delivery system is the challenge that you're faced with each and every day. How has Gundersen Health System been able to make that work?
One of the things that we've been able to accomplish in women's health is that we've been able to build a women's health center and really combine many of the specialties that women generally seek as primary care in one setting. And we are able to provide pretty much one-stop shopping in that particular center and identify what kind of specialty care they may need. They're then referred on from our primary care areas into the specialty care. So if they would need a joint replacement, or if they need a cardiology consult or more complex care in a different specialty, we're able to quickly refer them on to those specialties. In some cases, those specialties also come to the center.
Now, Pam, I know that there's people, I've heard them say this, they go to other places around the country and they don't offer this kind of, I'll say, service for women. Talk about that disparity.
That's a great advantage for us at Gundersen because we are able to provide an integrated healthcare system for women under our one roof, you might say. And in other parts of the country, they really need to build a center and then invite different specialty clinics into their center. We have the specialty clinics at Gundersen to provide that service right here. So we're at a tremendous advantage to providing very strong integrated health care for the populations we serve.
So if somebody hasn't been up to the Avery R. Gundersen Center for Women, one of our newest areas at Gundersen Health System, what are they going to see when they get there?
They're going to find an environment that's been very well designed with women in mind. It has very much of a warm, healing environment. We have specialty services within that area that we don't find in other areas of Gundersen, such as a boutique, a health resource library that's on the floor. We do a fair amount of our patient care by using the health resource library in that area. Physical therapy is on that floor, along with mammography, diagnostic mammography, OBGYN, family medicine, and internal medicine. And we also are adding some additional specialties as women have identified what else they would like to see there. Some of the specialties that we're also bringing into that area right now are services such as GI, and Dr. Child comes into the Center for Women, and so does Dr. Andresi, who is a urologist. So we try to bring the specialists into the center versus the patient needing to go to other specialists throughout the system.
One of the other things that's unique about the Avery R. Gundersen Center for Women is the fact that there's a boutique up there and there's a library there. Can you talk a little bit about why those services are offered?
The boutique is offered to provide some of the specialty products that are recommended for women in many of our different specialty clinics. So they don't have to go someplace else or go online to get these supplies. They're able to go right into the boutique and purchase them. We also have items available within the boutique that people may need in their pregnancy or as they're going through menopause, and some of the other items that providers do ask the patients to try. So those are available in the
all
center.
with easy access. And then there's a health resource library too. If someone has more questions, it's a place to go and maybe get some answers in a different way.
There is. One of the things we're piloting shortly is also having our library staff assist our patients in signing up for MyCare. So we're really trying to use the technology that is available to us and the information that's available within our technology services for better patient education.
We're talking with Pam Podesky, Gundersen Health System, about women's health. And one of the things that comes up from time to time is what's in the future?
One of the things I would say is in the future is we have to continually keep a very close eye on what women want. Women make healthcare decisions in all of our families approximately 85% of the time. So as healthcare providers, that's an enormous voice for us to pay attention to. And it's one of those things that as we move forward, I don't think we can make decisions without listening very carefully to what it is they want and how they want that delivered to them. So I would like to say primarily it's let's keep an eye on that consumer. She's pretty important.
Absolutely. And oh, by the way, I'm sure that women's health will be certainly well addressed in 2014 when the new hospital opens on the Gundersen campus in La Crosse. Pam, thanks for joining us.
Thanks, Chris.
And by the way, Gundersen is one of only 166 hospitals in the nation and among 6 in Wisconsin with patient outcomes for women that are in the top 5%. That according to the study from Health Grades. And again, we referenced that earlier in the interview with Pam.
And if you'd like more information on women's health, go to the Gundersen Health System website, gundersenhealth.org. Coming up next, when someone mentions Botox, what comes to mind? Reporter Brian Gilberts with the very latest on the different uses for Botox. I'm Christopher for It's Personal, brought to you by Gundersen Health System.
Is your weight keeping you on the sidelines, not participating in life? Jenny Roberge of Holman understands.
You don't realize how big you are until you see pictures after you've lost the weight, because you really don't feel like that. The morning of my surgery, I was 284 pounds. I've lost a total of 160. It was a lot bigger change than I expected. Just the response from colleagues, my friends, my family. Even up to the night of me having my surgery, I still didn't believe that I was going to go through this. But then I thought, you've tried everything.
Talk to the bariatric surgery team at Gundersen Health System.
The surgery will work for you. Physically, it will work for you. When I was heavy, I'd walk into an elevator, no one would even look at me. Now I walk into an elevator and 3 people look you in the eye, actually, and talk to you. I would recommend this to anybody that's struggling with their weight. I've gained my life back.
The Gundersen Bariatric Surgery Team has helped more than 1,300 people just like Jenny achieve their goals. Take your first step to a new life. Call Gundersen Health System today.
Welcome back to It's Personal, brought to you by Gundersen Health System. I'm Brian Gilberts. Botulinum toxin, more commonly known as Botox, is best known for cosmetic procedures such as treating wrinkles. But did you know Gundersen Health System is using it for a number of other medical treatments as well? I'm joined today by Dr. Christy Chappell, an ophthalmologist at Gundersen Health System, as we discuss how patients with eye muscle spasms can benefit from Botox treatment. Dr. Chappell, can we start by talking about the muscle spasms or the twitching around the eye and what these are?
Well, it's a type of muscle spasm in most cases that's going to go away, so that's the good news. The fancy name for those muscle spasms is myokymia, and what happens a lot of times is different things in people's lives can cause them to develop these spasms. If the spasms only last 1 to 3 weeks, then it's fine. They don't really need to seek medical care. But if they go on longer than 3 weeks, they really should come and see either their optometrist or their ophthalmologist. The muscle spasms around the eye, especially when one eye is spasming, are frequently caused by fatigue, so people aren't getting enough sleep, or sometimes from stress. New things have happened, sometimes unfortunately a death in the family, or even good stresses like marriages. That type of thing, trying to plan a wedding can make people very stressed, and I've had patients come in with myokymia that resolves on its own. Other problems are related to excess caffeine intake, and sometimes you'll have one person who comes in with all 3 problems. For example, students during finals, they stay up too late, they're very stressed because they have exams, and they're drinking too much coffee. And so when we are able to help people back off the caffeine, get some more sleep, reduce their stress with different types of techniques, or just get past the event that caused the stress in the first place, these things will go away. The spasms will stop on their own. Sometimes people come in right around 2 or 3 weeks because it's been going on a long time, and the real issue is that they have an eyelash pointing the wrong way, or they have very dry eye. And if we treat those things, then these things go away. Also, the spasms resolve on their own. So in most cases, the good news is this will resolve on its own and isn't really a serious medical condition. In those cases where it persists after 3 weeks, we really should see those people.
Are there any long-term effects if you don't get it treated?
The myokymia, this spasm that's self-limiting and goes away on its own, there really aren't any long-term effects. If it goes on to becoming some of the other conditions of muscle spasm around the face, for instance, blepharospasm, which is where both eyes start spasming, both the muscles around both eyes start spasming. So they start getting blinking, they can't control, they can't keep their eyes open. That can impact people's ability to drive, their comfort level in group situations. There's another type of spasm called hemifacial spasm, and hemi just means half. And so half of their face will start to spasm. These can cause a lot of social issues for people, but it also causes problems for them when they're eating or drinking. And those types of things really do need to be addressed because they're not going to go away on their own.
Okay, can you talk about some of the treatment options available for this?
When we're talking about the eye spasms, the most common first line of treatment is to address what are called ocular surface disorders. So sometimes people have dry eye or they have some other problem with the surface of their eye, and we try to address that first because many times that solves the issue. But if it's a true spasm where the muscles are spasming and both eyes are involved, many times we go on to a therapy called botulinum toxin. In the lay press today, it's called Botox. People are very familiar with that being used for wrinkles, but it has multiple uses. It can be used anytime you really want to stop an unwanted muscle spasm. So if people have blepharospasm, where both eyes are having muscle spasms around the eye causing this unwanted blinking, we can use the toxin from this bacteria called Clostridium botulinum. It makes a toxin that you can isolate and use by injecting into the muscle and stop those unwanted muscle spasms. So Botox is one of the most common techniques for blepharospasm and for a spasm of half the face.
Okay, we're talking today with Dr. Christy Chappell, an ophthalmologist at Gundersen Health System. So besides using the Botox around the eyes and so forth, this is a fairly new treatment available at Gundersen, correct?
Actually, no. Botox has been available. I've been here 15 years, and I've provided botulinum toxin injections for patients with blepharospasm, the blinking of the eyes, and hemifacial spasm, where one side of the face contracts, for the last 15 years. Prior to that, Dr. Ryan, who's now retired, also provided this service. It's interesting, Botox was actually used therapeutically by an ophthalmologist in the 1960s, a Dr. Alan Scott. He originally used it for crossed eyes. So he found that if he used botulinum toxin, he could reduce the eye crossing of some patients and avoid surgery. It's used sometimes now for that, but it's used more frequently for the eye spasms and the facial spasm. But actually, botulinum toxin as a therapeutic use has been around a long time. The use of it as a cosmetic agent to help inhibit wrinkles and that sort of thing came later, actually.
Okay. So what other uses are we using it for here at Gundersen?
Well, if you have problems with neck spasms, it's called cervical dystonia, and it's where you can have very uncomfortable neck spasms that move your neck in an uncomfortable position. Or if you have a problem with chronic migraine that lasts longer than 15 days a month, you're having it not occurring at least 15 days a month. It doesn't have to last that whole time. Other conditions, when you have spasm of the bladder, or in some neurologic conditions like Parkinson's disease or after stroke or cerebral palsy, it can be used to help relax the spasticity, the contractions that people experience, to make them more comfortable. It also helps people that have excessive sweating, and I'm not thinking about sweating like after you're running and you have sweating after exercise. This is sweating where a person can be just sitting comfortably and have excessive sweating. If those types of situations are occurring, then some of our neurologists can help you with Botox specific for these neck issues or bladder issues.
Okay. Dr. Chappell, anything else you'd like to include about the Botox and some of the different treatments here?
For botulinum toxin around the face, the good news for people is to know that there's minimal side effects. You can sometimes get a little bruise where the needles are used to inject the Botox. Sometimes if you get a side effect from Botox, it's related to the muscle that you injected it in. So if you were to inject around the eye, for instance, you will have a risk of a droopy eyelid. But the good news is, even if you got that side effect, Botox lasts typically about 3 months. The good news about Botox is that it lasts 3 months, so side effects are very minimal, or they go away completely. The bad news, of course, is if you got a great result with the Botox, it is a repetitive treatment. Now, some people, if you treat the underlying disorders, like if they have a surface disorder of the eye, you can sometimes get their Botox treatments out to every 6 months. So sometimes people can reduce the frequency of the Botox by treating any underlying disorder.
Okay, so does it eventually cure it, or is it always you mainly just kind of treating that?
Yeah, think of blepharospasm and hemifacial spasm and some of the other neurologic disorders like chronic migraine or spastic bladder as chronic diseases, more like you think of diabetes. So you take insulin or you take an oral agent, something you would take by mouth for your whole life to control it, but it can be well controlled. And that's the same way you should think about botulinum toxin. Even when it's being used to control frown lines and wrinkles as a cosmetic agent, it still will need to be repeated.
Okay, Dr. Chappell, thanks a lot for your time.
Oh, my pleasure.
For more information on the multiple uses for Botox offered at Gundersen, go to our website, gundersenhealth.org/BT. Advances in surgical techniques are giving people with arthritic knees an easier treatment option. Christopher will explain when we return. I'm Brian Gilberts for It's Personal, brought to you by Gundersen Health System.
When faced with traditional open heart surgery, Donald McDonald from the Twin Cities had something to say.
When my local doctors came and said it was time to do a double bypass through cracking my chest, I knew there had to be a better way. I mean, this is the 21st century.
Not one to accept the status quo, this pioneer set out to find a better way.
I started to research minimally invasive, and that's where our journey to Gundersen began. The one offered at Gundersen appeared to be the most complete treatment with the least amount of risk and the quickest recovery.
As a leader in minimally invasive cardiac surgery, Gundersen provides expertise and a level of care that is unmatched in our area.
Gundersen really was the right place with the right people with the right procedure, and I've got the correct outcome. You owe it to yourself to look at a second opinion. The technology and compassion at Gundersen is beyond excellent.
Gundersen Health System, where caring meets excellence. For more of Don's story and to get your own second opinion, go to gundersenhealth.org/second opinion.
Welcome back to It's Personal, brought to you by Gundersen Health System. I'm Christopher. Well, it used to be that total knee replacement was the best surgical option for people with chronic knee pain. But now, partial knee replacement is a practical option for many patients. Dr. Brad Fowler joins us now from Gundersen Sports Medicine to discuss this a little bit. First of all, let's talk a little bit about what is partial knee replacement.
Well, the knee can be broken down into three different parts. We got the medial, the lateral, and the kneecap joint. It's one joint, but you can think of it in three different separate areas. And typically, people will start to break down on the inside part first, or the medial side of their knee. And so when they present, they may have bad bone-on-bone pain in 1/3 of their knee, but the other 2/3 is still okay. Traditionally, we've done total knee replacements, meaning we've been replacing the whole knee or replacing 2/3 that maybe still didn't need to be replaced yet. And through technology now that we can do partial knees through small incisions and better pain control, we can do these things as an outpatient and just do just replacing that one side of the knee. The advantages is we can do it through a small incision. Recovery is much easier. We're doing it as an outpatient or overnight stay sometimes. And if it ever needs to be converted to a total knee, it's much easier to convert a partial knee back to a total knee than a total knee to another total knee.
It seems like an obvious answer, you know, if you're kind of throwing the baby out with the bathwater, if you got to replace the whole knee and you don't need to, it seems like a kind of an obvious thing. Is that what you're finding?
Yeah, and it's not so obvious. Partial knees have been around for a while. This isn't a brand new concept. When I trained back in the late 80s and early 90s, we were doing some. But back then, we had to do a total knee incision. So we'd make the same incision we do for a total knee. People stayed in the hospital for the same length of time. And when they failed, it wasn't necessarily easy to convert them. And so a lot of docs kind of got away from it. They said, this is not a great operation. And it wasn't at that time. But it really has evolved. And from the late 90s till now, it has really taken off to the point that we said just doing through this tiny little incision, which really makes a big difference for the rehab. So.
Let's talk a little bit about who might be candidates for this. We mentioned chronic knee pain, and you're saying that it can be, one of three different, areas that may need to be replaced. But because there is this option, are you seeing patients coming in younger?
We are. We are. And again, the old, back when I took my boards back in the 90s, the classic patient was a 70-year-old or older. And today we've actually gotten so the younger person actually makes more sense for this operation. So I'm seeing 40, 50-year-olds who are starting to wear out. They're bone on bone, the medial part of their knee. The other parts of the knee are okay, but they can't do what they want to do. And so we're doing the partial knees, and we're finding these things are lasting as long as the total knee. We're getting that 20 years. And so if we can get that 40-year-old to 60, they still might need a total knee, but they've gotten 20 years.
So you're having lots of conversations with younger people then
exactly.
about what's the most common partial knee replacement that you're doing?
The medial side, the inside part. And that's pretty exclusively what I'm doing is the inside part. Patellofemoral joint or the kneecap joint is gaining some popularity. I have not ventured into that yet. It's just not nearly as common that people need that. The lateral side is much less common that needs to be done. It's hard to get to the lateral side to do it through that small incision. And so you're obligated to do kind of the bigger incision. Well, if you do the bigger incision, oftentimes you're going to do the total knee. So you lose the benefit of this small incision.
Yeah. Is this something that, whereas this is now this option is available, should more people be looking into partial knee replacement?
I think so. I think that total knees are a great operation for the right person. And so if your knee is end stage, completely gone, cartilage isn't there, you're bone on bone throughout the whole knee, it's a great operation. It's not a great operation if you do it too soon. And so there's a lot of people in that gray area. They have pain, but they're not ready for a total knee yet. And I think this is going to be a nice something in between. One of the frustrating things we've had to offer people is we have injections, we have physical therapy, we have arthroscopy, we go in and clean a joint out, and then we have a total knee, and there's this huge gap of what we have to offer people. And this is something that's in between. And so someone who's having pain, they're not ready for a total knee, and they've talked to friends and family who've had total knees and maybe not been completely happy with it, and so they're hesitant to do something about it. This is something that's really in between. So I think it's very appropriate for that person who still wants to be active.
I don't want to gloss over it. You mentioned it earlier that this is an outpatient procedure sometimes. Can you talk a little bit more about that? It seems like something that is surprising when you think of...
Yeah. And that's really because, for two reasons. One is because we're able to do this, our instrumentation allows us to do this through a small incision. And so incision now is 3-4 inches long as opposed to a 10 or 12 inch incision for a total knee replacement. And that may be overestimating on a total knee, but it's a much longer incision. And we've got much better with injecting pain meds at the time of surgery. And so if we've got a small incision, we're able to really numb it up very well. The person may not have pain at all when they wake up from the surgery. And what we found is we can manage that with oral pain medicine that they can take at home. I traditionally kept people overnight. And for the last year, people have been telling me I didn't need to spend the night. And so the last few I've been doing is outpatients, and they've been very happy. And so I've really been switching to, not everyone's going to go home, but that is an option for most people.
Oh, that's really very interesting. We're talking with Dr. Brad Fowler, Gundersen Health System, and he's in sports medicine, talking about partial knee replacement. What are the bad sides? Is there a long recovery to this?
The recovery is amazingly short if you're used to looking at total knee replacement. People will come back often at a week to 2 weeks, no crutches, walking normally. And they seem to fly through their recovery. So when I'm seeing people back and they got both knees, I've had people as soon as 3 or 4 weeks say, let's do the other knee. So that's the advantage. The disadvantage is, could the other parts of the knee wear out and you have to convert it to a total knee? And that's certainly a possibility. The partial knees, the studies we have on partial knees, they seem to be lasting at 20 years 85 to 90%, whereas total knees will last 90 to 95%. So they're not lasting quite as long as a total, but pretty close. And to convert it, it's not as easy to do a conversion of a partial knee to a total as a normal knee to a total.
Okay.
So there is some technical issues there, but it's easier to convert a partial knee to a total than to revise a total knee.
Give you a chance to pull out your crystal ball here. Where do you see knee replacement surgeries headed in the future? Partial, or
well,
full?
I think partial knees are certainly on the upswing. There are clinics in the country that are now total joint clinics. They're now doing 50% of their joints are partial knees. And here at Gundersen, we are just doing a few percent. And so there's certainly a lot of room to grow. National averages are probably around 25% of people getting partial knees versus totals. So I think there's a lot of people out there that could benefit from it. They're just kind of sitting on the sidelines knowing they want something, but they don't want a total knee, and this may be the answer for them.
It seems like a unique answer, that's for sure. And if people want to have more information about it, they can certainly go to the Gundersen Health System website. That's gundersenhealth.org. Again, if you'd like more information about partial knee replacement or any information about any of the topics discussed on It's Personal, you can go to that web address, and we encourage you to do so. Dr. Fowler, thanks for your time.
Thank you.
And that wraps it up for this edition of It's Personal, brought to you by Gundersen Health System. For Brian Gilberts, I'm Chris Stauffer. Thanks for joining us.